Set the board, like give me some key things so that I can go, grab, look, review, give me 10 seconds to review this, walk in. How do you remember that, right? So you become this team that becomes a superpower.
The servant leaders, they're behind the scenes, and they allow the space for people to grow into. And I think that's a really important comment.
You got $50 for 60 people. Like that puts you in a whole different bracket of like compensation. You have to quantify these things and bring the value to your pages like you do your team. Today's team. Look, you're on vacation. You have the ability to make a lot more than your base salary or hourly if you're an A player.
The reemployment rate is like 95 or above. That's the one thing that relates to the most healthy, productive, profitable business out there.
The DSO sits above and the profits flow up. It allows the marketplace to become the world for your practice. So your valuation can go up.
It's actually been really great.
Yeah.
It's really been great to get me past some of the plateaus and obstacles I've had in my practice growth and development.
And I've been blown away by both of them. I've been studying from afar, I've been learning from them, and they both are incredibly genuine people, it seems like, and they want to help. And so when I heard they were putting on an event at the last Voices of Dentistry, they made a mention of it. I walked up to them and said, I'm going to be there.
And a lot of people here are the same way. I think that's why this is such a cool summit. It's different than any other CE because it brings like-minded people together. And I hope they throw it again next year because I'll be here.
I want to kind of talk about some cool biohacks that you know about, and you and I have kind of talked about some just privately. But one thing I've learned is, and I want you to poke holes in this, is the biggest and easiest, lowest hanging fruit for longevity is intermittent fasting. Can you talk about the positives and the negatives?
My wife's all about it. This might be the first podcast my wife ever listens to from me.
So, where that comes from is the calorie restriction literature. So, and they felt like, I guess it worked in worms, so maybe it's good for humans. And so the best studies were done with worms and then mice actually. So it got a little closer to us. And so then there was some extrapolation for that, but there's a lot of similar sort of stimulation with that. So calorie restriction, even with, so the studies done with them was like 25% reduction in calories, but most humans won't refuse to do that. But even 10% reduction in calories could do that.
But is this all about, so here's what I want to know is like, the studies I've read that basically says that if you can, it doesn't matter when you fast, as long as you can kind of like break your eating window down to 8 hours a day, right? So you're fasting for 16 hours a day. So that means basically a big lunch and a big dinner, and then you're kind of done, or however you want to break it up. But, and you mentioned it was a caloric restriction, but isn't it also about an insulin and insulin resistance and not wearing out your kind of, like our modern day diet has our insulin spiking and then it stays up top and it kind of wears our system down and it spikes again in our next meal.
That's right.
So maybe you can kind of break this down a little bit for me, because I think it's,
that's really part of it.
People to adopt if it's valid, and it was the only thing I should mention. Craig, maybe we haven't mentioned in our podcast, but intermittent fasting and the ketogenic diet was the only thing that helped me kind of shed some pounds when I was in that fitness competition, and it was effortless. Like,
what fitness competition are we talking about?
I did it a long time, but no, a fitness competition with my buddies, not on stage.
Oh, I thought this was like the Mr.
I was flexing.
It's like Naked and Afraid or something.
Yeah, exactly.
The skinny
I pictured you in like a one-piece bikini and like fake tan.
It was
with a Tupperware and a
the skinny fat guy competition, Craig.
Dude, I'll kill you on that one.
You'll kill me, the dad bod universe.
Oh man, I got 7 years on you, Pete. Just wait.
So, yeah. So I want to know more about, is it the window? Is it the restriction? Is it all about insulin? What is it?
Yeah, so it's all those things. So the simplest thing looking at calorie restriction is true. So overall calorie restriction works, right? And so and part of it is because we're doing calorie restriction, we're decreasing the stress on the body. It's supposedly decreasing the free radical, the oxidative state there too. You're decreasing your insulin, so insulin level is falling down, lower because you're not stressing the system. And it is about carbohydrate control as well. So it is about, so the simplest, calorie restriction. And then they looked at, well, what if we did some of this fasting, and some people do daily fasting where they fast overnight. So the simplest other next step would be overnight fasting. So every night doing a 12-hour fast, not eating after dinner. So by later in the that fasting state, your insulin level falls to the lowest, and then you actually are probably using more fatty acids for fuel those later hours of the fast. If you prolong it a little more, then that's pronounced, right? So the 18-hour fast, that's where this intermittent fasting comes in. And commonly people will do this 5 and 2 sort of rotation where, maybe 5 days a week, they just won't eat after supper.
Mm-hmm.
And then 2 days a week, they won't eat after lunch, or something, or make an 18-hour fast out of it.
I have a quick question. Fasting, does that mean like no food whatsoever, no drinks, would it mess up your fast if you had, let's say, coffee or something?
Coffee doesn't break fast, right, Doc?
So hydration is fine. So it's really food. And then some people do carbohydrate fast where they may eat something, but they don't eat 0 carbs. So there's a lot of variation on the theme, but you could drink, but not have food or anything that's going to stimulate an insulin response.
Interesting.
So
I'm not eating very much during the day anymore, which is really strange. I'm having coffee, but I'm just not finding, number one, I don't find the time, but I'm not eating like just lately, like breakfast, lunch at all. I don't know. I just
you put all your calories at nighttime?
Yeah. It's like, I think it's called the sumo wrestler diet.
To
try to make weight for the next weight class. No, I'm not kidding. I think it's probably bad for me, right?
Yeah. So metabolically, you're kind of going opposite of what the normal diurnal pattern, should be. Even the people that skip breakfast and do this intermittent fasting, they'll eat lunch and dinner and then not eat again until lunch. When we look at what our cortisol levels are supposed to do, you're supposed to wake up in the morning. Your cortisol rises for the first half of the day and then falls off around noontime. So I kind of look at that, and that's kind of going against the grain a little bit. I guess if you're healthy enough and you can compensate for that, that's fine. But I see, the people I see are people that have chronic stress and have adrenal dysfunction, and so they actually don't do as well if they skip the morning time. So they need to feed their adrenals, I tell them, in the first half of the day. So if you're going to do that intermittent fasting.
Hey, Pete, would you mind if we take the next 30, 40 minutes and just make this all about me, and I could get my one-on-one consultation with Dr. Flowers? Is that cool with you and probably the listeners?
I love it. Yeah. Let's just have a Spodak consultation.
Is that okay? And we'll record it for the, because actually it'd be pretty comical for people to learn how I'm bringing everything up.
It could get quite personal though.
Yeah,
I'm an open book, I actually,
so one of the more popular things that's going on in the narrative of, in what we're talking about too, is there's a lot of techies and biohackers are taking metformin.
Wow. Isn't that like for breast
diabetes.
cancer?
No, diabetes. Right, Doc? It's
right. Mm-hmm.
Oh.
So basically, to the extent of kind of talking about,
I'm thinking methotrexate, sorry.
But it's they're taking it from a longevity perspective because it's anti-cancer functions like that. So I'm trying to draw a loop onto the caloric restriction and how there's potentially some evidence of being anti-cancer.
Right, exactly. Cancer loves sugar.
Cancer loves
know
sugar.
Ooh, that's a great little one there.
That's why when we talked about controlling inflammation, oxidation, and glucose, that's also the risk factors for cancer. Especially someone who's had a cancer or has one, then low carbohydrate nutrition is essential to do that. So that's part of the reason why that is.
Yes.
So Doc, you're not consuming any sugar, huh?
So I don't consume simple sugars, except for occasional cocktails, except for bourbon. That's
your vice.
That's my vice. So, but I don't really eat bread. I don't eat sandwiches. I do eat meat. But mostly a plant-based diet. It's not that I would never have a piece of cheesecake, but in general I don't. And the other thing is thinking about, look at like a dinner, like if you go to dinner at some Italian restaurant or something, so there's bread on the table, there's pasta that's coming, there's wine, then there's cake at the end, or some kind of
normal Friday night for me.
So it's just if you count up all the carbs, it's just huge. And so what I do personally and what I talk about doing is like, well, you're not totally depriving. You just pick, okay, what's going to be your favorite carb, and so for me, I want the red wine. So I'm not necessarily going to have the bread. I'm not going to do all the other stuff. I'll kind of pick what's going to be, my favorite, for that time.
Wow.
You know?
And the amazing
I like
thing,
the all-you-can-eat breadsticks too, Craig.
yeah, no, Pete, we've eaten together many a time, and Pete and I like eat like we're Beavis and Butthead or something like that. But it's amazing for those of you who are not listening to the video. Doc looks probably like he's about maybe right around Pete and our age, in the low 40s, but he's actually 137 years old.
Yeah,
That's exactly
136 years old. It's incredible.
Like a young Yoda.
So yeah, he's literally like a taller, more hirsute Yoda.
That's it. So to kind of talk, about the sugar, that's kind of where that comes in as far as helping to get insulin control, glucose control with that diet.
And then me bring up that metformin. That's kind of a hack for preventing sugar spikes and what am I trying to say?
So it's improved the utilization of insulin, right? So and it may do some other things like promote something called AMPK, which is found to help with the energy cycle, and one of the things that probably is protecting the cell. And it could be even working, this whole kind of genetic influence, right? So that's how fasting works, and that's how things like metformin or even like resveratrol, a very common one that people say, oh, they're fasting mimicking compounds. And so instead of actually doing the work to do, a calorie restriction, they want these other things to try to mimic that. And so that's kind of how metformin works.
Okay. So, and there's something called the mTOR pathway too, right?
That's not caveat. That's caveat mTOR. It's just buyer beware is what you're talking about, right? I'm sorry. This is just getting so far off in the.
All right. Sorry.
I was not here.
We won't go down. All right. But I do want to talk about, so let's talk about Bulletproof coffee, because how do you feel about that from a physical fitness standpoint? How do you feel about it from a health standpoint? Is it okay to do in a?
Well, it also can depend on your genetics, right? So if you're doing a big saturated fat load, then in the person who's genetically susceptible, I've seen that actually influence their cholesterol.
Mm-hmm.
And people that can handle that and they're not hyperabsorbers, then may not necessarily influence their cholesterol. And of course, butter is one of the things with that saturated fat seem to influence LDL cholesterol more than, say, some other saturated fats like in the meat or something like that. So it's just a fact that also that it's low
candidate for that. Is that
low carb, not necessarily, right?
Yeah.
So the majority of people would do fine, but we find the select people that that might be a problem. And same with the different forms of keto diet, right? So ketogenic, really the essential is that it's low carb. But people have kind of tried to promote ketosis by adding in a high fat diet with that. And so when I see the people who are genetically predisposed, they go from normal cholesterols to cholesterols of like 300 and something, So, but not everybody, but then, those are genetically susceptible people. So, and then, and they could do just low carb. They don't have to do such high fat, So for those people, it's not worth it to do that.
So the other thing you just mentioned that I don't want to gloss over is resveratrol, right? And that's been a hot topic. That and the NMN molecule, which is nicotinamide mononucleotide.
Oh
right.
My gosh.
Right.
Should I just
The
log
NR,
off?
Well, hold on, Craig. It's easy. It's NMN. So this is on Joe Rogan for just recently with a guy at Harvard. I forget his name, Dr. David, whatever. But it was a very downloaded podcast, and this was a longevity podcast he was talking about. And he actually talked about stuff like metformin and stuff like that. But basically, this being how NMN and resveratrol work kind of together synergistically to kind of help mimic the effects of sirtuins.
That's right.
Sirtuin genes. Can you talk about that for a second? Like what a sirtuin is? Because that's maybe one of the first time that people have heard of a sirtuin.
So the sirtuin genes are the ones that they're doing sort of at the cellular level, protecting the cell, and they take the cells into sort of maintenance phases. And so a lot of times might be why they're protecting us from cancer. They're promoting the cell to kind of be in steady state and repair and not in constant turnover. So protecting yourself and longevity is not necessarily about increasing your rate of cell turnover. You want to increase the rate of maintenance and repair. And so that's part of why the sirtuin gene is doing that. And then there's another set of genes related to kind of body weight is the FOXO genes, right? So that's part of how some of these
say
compounds
FOXO?
are work. FOXO3, FOXO.
Wow.
And so that can be one of the genes that's kind of related to sort of our obesity thermostat, if you would. And then depending on if you have a variability in that gene, we think that might be one of the other things that might predispose someone to be obese, whereas another person is not.
And we all remember that, everyone distinctly, all the dentists remember the Krebs cycle. So this is all relating back to mitochondrial function, right?
Exactly.
Okay.
And so it's protecting the mitochondria. And so the other things that these things are doing is probably reducing oxidative damage in the cell. So the NMN or the nicotinamide ribosides, the NR1, that's a popular one now that they're selling as a supplement. It's supposed to be partly protective there, and it's supposed to be creating something called NAD+, which is sort of the thing that's supposed to help with protect the mitochondria.
But you can't ingest NAD+ because it doesn't pass the gut. You have to take the precursors to it, which are NMN.
Right. Or we can give it IV.
You can give NAD IV.
IV.
Yeah. So Craig, I know
like
you're kind of glossing
glutathione,
over
too.
like what the hell are you talking about? But this is important because it's not just a longevity thing. It actually is it's a reversal of, and so because there's a decline in metabolic function that happens in the mitochondria, right? So it kind of helps rev that back up.
Part of me just I know you guys are both very enthusiastic about this stuff, and I have a lot of patients who are what do you call it? I guess you guys are biohackers. You guys like to.
I mean, I wouldn't classify neither one of us as biohackers, but.
Well, I mean, like it almost feels like I hope that at the end of this, conversation, I'm not saying that we're needing to end, but at the end, I'd love to have like, what are the top 5 things?
What's the takeaway?
Yeah, well, not even that because it's all valuable, but it's like for the average person. I mean, I like to think of myself as like, nutritionally more savvy than the average person. And I imagine our audience of, medical professionals and auxiliary dental professionals is more savvy than the average person. But this seems like a lot to me. And I wonder, like, most people are struggling just to drink enough water or, get enough sleep. So it's like, I think that at the end of this conversation, I'd love to have a top 5. Like, what are the 5 easiest things to do?
But I think you make a very good point. And so kind of going back to foundation. So why should someone go and take NMN or resveratrol or get NAD injected if they're not even paying attention to their nutrition, their sleep, even hormonal balance,
and the water,
all those
that's
things,
a great thing, Craig. You're right.
The hydration,
chronically dehydrated.
Because those are the things that's what also protects the cell. So these things that we're talking about, it's clearly over and above, so I would never just start someone out and say, hey, you should really go, do these things. In fact, almost always we're in the foundation and mid-level and not kind of going to that, unless someone's kind of already got all that tidied up, then we're kind of looking at, okay, what's the next thing? And we're also trying to measure how effective that we're doing. So that's the other kind of challenge with, doing NMM or some of those other things. Right now, the studies actually with those show that giving that sure raises NAD+, it looks like, but there's not been any big studies in humans that have done kind of the outcomes with that. So we're seeing there's some extrapolation with what it looks like it happens biochemically and what happens I love it, they call them preclinical studies, which means they're not human. So
I love it.
There's not really the human studies that kind of prove, that with some of these things, it looks promising. So that's why I say you got to do the foundation first. And then if you're interested and you want to go to the next level and you can do these things. But
thanks for pulling it back in, Craig. I could have.
No, it's just I appreciate it. I appreciate it, but you guys are you're so granular because you're so into this. I'm like I hear it. It's all good, but I just wonder what are the takeaways. Most of us, I do believe, are struggling with the water and the sleep and the blah blah blah.
Right. And then calorie, your nutrition and calorie restriction and timing, and maybe intermittent fasting, or even the other thing that's really, there's some good research on is fasting mimicking diets, right? So instead of doing a prolonged fast where people just do a water diet for, 3 to 5 days, you can actually do a fasting mimicking where it's a lower calorie diet with the right nutrients. And that has some great regenerative effects with that. So some very good studies. Longo out of UCLA, the Institute for Longevity, he spent the past 20 years kind of researching this. And he kind of came about it looking at this thing called the blue zones where all the centenarians live in the world, and why are they healthy, and what do they do, and what do they eat, and how do they live. And he sort of backed into this from sort of a biochemistry standpoint and a nutrition standpoint. And I think that's got some legs. That's really going to be something that's going to be impactful that anybody could do.
What are a few things that are really exciting you about the advances in medicine, or whether it's, like bioprinting or whatever? Like, what do you see? What are you really excited about that you see happening in our lifetime? Or
so when we have a better understanding of the genomic piece, right?
Mm-hmm.
So it's not static. Like people used to think, like, oh, I have that gene, I have X% risk of heart attack. But our genes are dynamic. We know when I was in school, there's just started this thing called the Human Genome Project. We thought, hey, we're going to have all the answers. I remember my genetics class having that discussion. Now, our food changes that. Our food changes our genetic expression. That's why you're not locked in necessarily if you have some of these genes. And I'm sure when you first looked at all those, we all have all these different gene variants, and people literally just kind of get freaked out when they look at I have all these abnormalities. Well, we all have them, and there's a lot of duplicity in our genetic code, for that reason. But we can change that. Our food changes our genetic expression, and then also the influence with pharmacogenomics. Like before you inject somebody with a medicine or numbing medicine, or give them an antibiotic or even a pain medicine, we should really know what is going to be their likely response, based on their genetics and how they're going to.
So more customized medicine based on your genomic profile.
Yeah, so more precision, with that, so we know, and then that really needs to permeate. It's just now kind of getting into a few of the bigger centers with looking at either drug responses, such as some of the cardiovascular drugs like Coumadin, the blood thinners, or something like clopidogrel. But even like chemotherapy now. So sometimes they're basing chemotherapies based on what your genetic marker is, and like we know the slow code gene is going to increase your risk for having a bad reaction to statins. So the cardiologist should know that before they prescribe that, right?
But it's not looked at. So I've literally got, anyway, I was literally on the wrong statin, Craig. I mean, they all didn't agree with me, but like from a genetic profile, I was on the wrong one, and it was actually, I don't know what it was doing. I forget now, but like that was never looked at because the cardiologist said, here you go, take this, because everyone gets a statin kind of thing.
Yeah. And it's still the trial and error kind of phase.
The trial and error. Yeah.
Given the advanced technology we have, just like not measuring for a crown. You just kind of, we'll just keep fitting ones on, and you let me know, come back next week.
Let me know when you don't have a headache and your jaw.
Right. Exactly. So we should be able to do that with more precision.
I have a question.
Go ahead.
Sorry, I just have a question. Are you aware of any studies that correlate spirituality, or I don't know how to measure them. What I'm trying to say is there some form of like people that live in a spirit of gratitude or have a sense of spiritual identity? Is spirituality promote longevity as far as you know?
Yeah, absolutely. And part of that is because when people have faith, then they have, I guess, not really more of a sense of control, or they don't feel like, there's less maybe worry with that, I think. But it also kind of our spiritual practice literally helps our brain to settle down and to deal with that and to restore. Certainly a lot of studies with yoga and meditation related to that. Brings down blood pressure, lowers cortisol, changes your brain waves, changes your blood pressure. Even weight changes with people that have a regular practice that's like that. I think that we all have a spiritual component, regardless of religion, right? Those are two separate things, So I think that's part of our stress response in our body, that we have this spiritual component. And so the people that do the best are the people that pay attention to that and they do something with that, you know, so it's not just,
The reason why I ask is because there's almost, you know, I had a patient that came in the office recently and she was obviously not well. She was germophobic, but to such a level that she couldn't touch the doors. And she, you know, so I think that, you know, there's almost, you know, right now we, at the present time, there's no escaping death. We can prolong our life. We can, but at what expense and what level of stress? And we all know that stress is related to sickness. And there has to be this happy medium of like, let's pursue what's within our reach, but also enjoyment of life as well. I think that the people in the blue zones, like Okinawa, whatever, you know, I know those people, they're fishing village and they're probably not too concerned about like what's going on Instagram and that this doctor is seeing a full mouth Friday and I'm not. So I think that in the age of upward and social comparison, there's also this X factor that's going to make us sicker as well. Societal pressure that we don't have enough. And there's Pete and I talk about this article all the time. It's called The Disease of More, written by Mark Manson, and that human beings like to be at a level 7 of happiness. Someone dies, you go to a 0. Over time, you go back to a 7. You hit the lottery, you go to a 10. Over time, you go back to a 7. So I think that there's a lot of mental unhealth in dentistry, and I think that it's being compounded by what other people think. And I just wanted to point out that there's the X factor of what you believe in your spiritual identity and your practice of gratitude that probably has just as much healing effects.
Absolutely. And I think as practitioners, we have to have a good place for ourselves, right? Because, you know, when patients come into the practice, they sense what the energy is there. They sense the culture. So not only us, but my staff, right? So kind of the way we approach that is like, you know, I can't hire someone and make them nice.
Yeah.
You know, I have to hire people that come with that certain skill set, that personal set. They're genuine. And that's kind of how, you know, and Pete can attest to that. It's like, they're genuinely glad you're there. They genuinely want to help you. We'll do everything to make not only just happy, but your experience excellent. So that's kind of how our approach is. We think that's a part of the healing environment. So how you're received when you come, you know, and also the physical environment. So that's the other thing about integrated medicine that may be different. We take into account what our physical environment is when you're here and how you might respond to that emotionally. You know, so all the people need to be aware and on the same page, and it's a part of a healing experience. You know, because coming to the dentist is one of the most stressful things. You know, it's like the last thing I want them to do is take my blood pressure when I go to the dentist. I don't know why you guys want to do that, but it's like, this is the last place you need to take my blood pressure.
Well, that's more of a CYA kind of thing. We don't want
I understand.
Well, and I guess some people were the first line of being like, they haven't seen a physician. It's like, hey, did you know that you need to go see a doctor like this afternoon? So let's go back to Craig for a second. Since you do see out of towners, and I want people listening to say like, wow, he sounds like my kind of guy. Dr. Flowers, how does that happen? How do people typically do that?
Yeah, so typically I like to have people call and we do some kind of phone consult to kind of get to know you a little bit, understand what your goals are, what are your health issues, if any, and then we'll talk about what would our approach would be. I need to see people, you know, we do a face-to-face in the office. So the initial visits, 2 to 3 hours, we go through everything, physical exam, all your labs. I get labs, everything ahead of time because I want to sit down and take the time to digest all of this. So it's extensive history that we get from you. And, you know, that, you know, 2 to 3 page plan that you got, I sit down, I do that ahead of time. So then when we meet, we're productive.
Yeah.
You know, we have something to do. We're going to collaborate. We're going to go through all of it together, have a plan.
A plan.
So,
I think that's the key thing that the takeaway. You know, I think everyone, if they know what's ahead of them and they have a plan, that's what I liked about it. It's like, here's the thing. These are good. These things suck. Let's work on this stuff. And like, you know, and we'll circle back up in 6 months. And if it's working.
And it's all explicit. And so then the second half of that is our nurse, Misty, who's also fellowship trained. She's one of the few master's prepared integrative medicine nurses in the country. And so she's kind of the coach. She's looking at, okay, gets into the very details of your life. What do you do? What's going to be your obstacle? Try to anticipate that, because there's a lot. People come here, you know, not to get a prescription for aspirin, right? We're going to do a lot, and we're doing this, and it's comprehensive, and we try to fit it together and so you can execute the plan, you know, because there's got to be a coach to help you do that and kind of boil it down. And then we partner, so it's available. So you literally join the practice, and so we're in this together. There's usually questions as we go along, and then quarterly we're going to be checking labs and following up. The follow-ups when people are away, we do teleconferencing. So we figured that out.
One of the cool things too, I want to interject this, Craig, because I think you'll see value from it, is like literally I have vitamins that are made just for me based on all the data, right? And so many of us will go, I used to go to GNC and buy the Men's Health and vitamin and pop it down, right? But like, so I think that goes back to the customized medicine that we talked about as being the future. And I think that that's a cool thing because Dr. Flowers can modify or augment some of the things that I may need in my form, call it the formulation based on what I'm presenting at that point in time.
That's cool.
Anyway, I just wanted to interject that because I think that's a cool thing. And that's really helped me kind of get away from the statins and stuff and him trying to address it from a nutraceutical standpoint as opposed to a pharmaceutical standpoint.
Yeah, that's exactly right.
So
nutritional medicine and that's our medicine. That's why it's so important, the quality. So even when we're using off the shelf, we're using pharmacy grade because I need to know that it exactly has that and not have some contaminant or other ingredient that's not listed on the box. And as we've seen from some of the studies that pull off the shelf products from the stores, it's a lot of variability with that. It's a self-regulated industry.
Yeah.
So we use companies that do self-regulate and they monitor, they certify their content. And so I know, because that's very important because that's my medicine for you.
Yeah.
And so I want to know for sure, what we've got.
That's awesome.
That's cool. Well, Doc, we've consumed enough time. I'm glad. I'm going to put some of the best way in the show notes for you to get a hold of you, but it's flowersmedical.com, right? That's your website. And then we'll put some links on to kind of that from our site as well, but that's how people would get a hold of you. And I guess
that's great. Yeah. We'll be glad to do it and love to talk to anybody that wants to just get an idea about what they're
Craig's writing it down right now. He's going.
No, I've been on it already. Flowers Medical Group. Oh, no, not Flowers Medical Group, Flowers Medical.
flowersmedical.com.
Yeah, flowersmedical.com.
Flowersmedical.com. Or if you Google Flowers Medical Group, you'll find us too.
Cool. Well, thanks so much for spending the time. It's pretty rare that you get this much time with a physician again, and I appreciate you taking the time to do it with us and on the podcast.
Yeah, it was
great.
Really
Thanks, guys, for having me.
Thank you, guys.
All right.
Okay, good. See you soon.
Take care.
Bye-bye.
Take care, guys.